I'm Jennifer Pollard Ruiz. I'm a family physician and community doc here in Austin, and I'm really excited to share a little bit about narrative medicine with you this morning and how it can help us have more work well-being. So I want to say thank you to Brian and Michelle and Chantel for giving me the opportunity to be here. And wow, what amazing speakers we have had. They've really taken us on this amazing, nourishing journey. So our learning objectives are here on the slide. I'm going to really be mindful of time. So in these 25 minutes, I'm going to kind of jump back and forth between giving some definitions and frameworks for burnout and well-being, and then the narrative medicine perspective. And then you'll have an opportunity to jump in. So I'm going to do that for 10 or 12 minutes, and then invite everyone to practice some narrative medicine for yourself. So if you don't have something to write on, if you've used all your beautiful notebook paper that was supplied for us this morning, just go ahead and raise your hand so we can get that to you now. Thank you. Yeah, just so we have that for later. Okay, because you'll need that in a bit. So overall, our goal here is just to have some stress-free time, stretch some different muscles. We don't need to solve our problems or others' problems right now. You don't need to know the right answer. We'll put our algorithm-driven brains aside and just have a little fun. So I'm a visual person. I have lots of slides. And I want to start with something that I think is very interesting. So like many of you, I finished my training before 2005, before that actually, but who's counting? So this is from a 2021 article, though, by hematologist Tate Schonefeld and team. And they research physician well-being at Stanford. And their view is that there have been 3 distinct recent eras of medical culture, each characterized by different norms and attitudes with respect to physician well-being. And prior to 2005 was the era of distress, okay? It's up there on the left. And this was a time characterized by a lack of awareness, rigidity, and even deliberate neglect of physician distress. And we live with a lot of, repercussions of this era today still. The good news is that we've moved into the era of well-being 1.0, right there in the middle. And this is a time characterized by more awareness and knowledge. So we have a vocabulary now for physician well-being. So I'm going to describe some of those terms now, like this buzzword that we've heard a lot about today, burnout. And I'd like to offer this definition of burnout as a syndrome described in the 3 domains of the Maslow inventory. And they're here on the slide. So they're emotional exhaustion, depersonalization, and a sense of reduced accomplishment. And burnout surfaces in our workplace ecosystems as cynicism and exasperation with patients. It makes us more prone to error. And what we really care about, our connection to patients and the quality of patient care, can be diminished. Physician burnout imperils the triple aim as it's associated with lower patient satisfaction, reduced health outcomes, and increased costs, not just related to direct healthcare costs, but also costs related to attrition and loss of the healthcare workforce. And the numbers, you guys have seen, heard, and experienced these, so I'll just hit some highlights from various national surveys that have come out over the last 2 years. This year's Surgeon General's Advisory on Health Worker Burnout says that even pre-pandemic, we were at crisis levels, okay? 35% of primary care physicians say they're unhappy with their work life. Up to 54% of physicians report symptoms of burnout. And over 20% of all physicians admit to having thoughts of suicide. So we're not alone. 2 additional related terms here are moral distress and moral injury. Moral distress happens when we know the best healthcare decision to make, but we're unable to act on it due to limited resources or other circumstances that are beyond our control. We've heard a lot about control this morning. It's an experience of helplessness, okay? Sustained moral distress can lead to moral injury, which has been linked to feelings of profound guilt, shame, and anger. So to address burnout and moral distress and injury, in the midst of all this, what do we do? The AMA tells us that some of the strategies we should use to take care of ourselves, among other things, is to remember the importance and meaning of our work. So how should we propose to do this when, as Brian Sayers put it in a blog from 2021, in the best of times, it can be challenging to fully connect with the joy and meaning that our work should bring to us, and these are not the best of times. So I just want to take a moment to acknowledge that much of what contributes to burnout is out of our control. It's socio-political, institutional, organizational, etc. And as physicians, we're also intertwined with how our patients are navigating the challenges brought by institutions and social structures that are at times unjust. And this is otherwise known as the healthcare system. Physician burnout must be addressed through policy and institutional organizational transformation, and these are the shifts that will move us into the era of well-being 2.0. But I would also offer here that within whichever socio-political structural framework we're in, we also hold our narratives, our stories of how we experience and witness individually and in community the struggles of the human condition. So let's now look at this through a narrative medicine lens that says that the care of the sick unfolds in stories, and the central event of healthcare occurs when the patient gives an account of self and the clinician skillfully receives it. So the definition of narrative medicine that I'll offer here is that it is clinical practice fortified by a knowledge of what to do with stories. It's what we know about how we tell and receive stories, and our abilities to recognize, absorb, interpret, honor, and act on the stories and plights of others. So this is according to Dr. Rita Sharon. This is her. She's an internist at Columbia, and she founded the field of narrative medicine in 2001. They published this textbook in 2017. So when you guys see quotes on the slide during this lecture, it's from the text or lectures by these folks. So this is how they talk about burnout. They say, it is not possible to shut out the suffering of others. It will find a way into your mental life, or keeping it at bay will be psychically costly and contribute to burnout. They acknowledge that we can become overwhelmed by fear, conditions of economic injustice, and health disparities, and by the sheer complexity of illness and its ramifications, and then we experience an emotional dampening. And so this is the issue for us as physicians here today, is where can we attend to this emotional dampening? How do we find meaning again? Where is the space for that work and the time, right? So narrative medicine invites us to reveal where that meaning lies for us, to remember how we are part of the human experience, because we're part of it also. To improve the quality of our connection to patients and improve healthcare quality overall by making it more just and effective. So here we can safely explore the rich complexity and relational dynamics of stories, the different perspectives and aspects of personal and cultural identity, and our own judgments, biases, and projections onto others. And this allows us to imagine the situation of others more deeply and with more awareness. So we become interested in what provokes our own reactions and also how the story itself is working on us. So social connection, relational skills, and these involve being able to see our stories in the stories of others and being able to see their stories in ourselves. And this is where we can attend to that emotional dampening. This is a 2018 study published by Dr. Deepu Gowda and team that showed that we build tolerance for uncertainty and ambiguity when we practice narrative medicine, and that we get more comfortable with vulnerability. Like I said earlier, narrative medicine is a discipline in the health humanities, and this is from a 2020 report by the AAMC on the role of the arts and humanities in medical education. And you can see narrative medicine up at the top of the table on the left. So health humanities work, it's interesting. It can help us build some of the structures and skills that oppose burnout, like work well-being and resilience. And resilience I'll define here as the ability of a person, community, or system to withstand, adapt, recover, rebound, or even grow from adversity, stress, or trauma. It's a kind of dynamic, adaptive capacity and a skill that helps us at the individual, community, and organizational levels to move toward a well-being 2.0 paradigm. So at this point, you may be asking, okay, so what are these methods and skills exactly? Narrative medicine methods are not like other protocols we learn to practice on patients directly, really. The stories or texts that we use are usually not even medical per se. But as great works, they often deal with themes of illness, wellness, life and death, joy and triumph, as we do in our work every day. So in narrative medicine sessions, the facilitator pre-selects texts that align with the objectives of the group text. So not from here. The text is where we focus our attention, and they can be visual art, a poem, short story, performance piece, film clip, or a piece of music. And then each session is built around the text with a facilitated close reading, exercise, writing prompts, and discussion. If a text is visual or auditory, we practice slow looking and attentive listening. We notice narrative structures such as voice, use of time, metaphor, and imagery, not to analyze or criticize, not to compare or contrast or get the right answer, but we use them as devices to go deeper into the text and into our own unique responses to it. So we're not concerned so much with the facts of the text, but actually with the multiplicity of ways that each reader may engage with it. And so these are quotes again from another instructor in narrative medicine named Rika Burnham. And she says that this makes the text come alive on its own terms for each of us. So as we begin with this first exercise this morning, still morning, just be open and curious about where this text takes you. We want to, as Rika says, observe the text with our senses, to inhabit them, to look around and see what it's like to be inside of them, to be inside these other worlds, these other realities. So right now, let's just take 30 quiet seconds to do nothing else, but look slowly at this text, and I'll watch the time. So go ahead and start now. Okay, so we'll come back together now. And then we're going to go right into another exercise. So we're going to look again, and this time for about a minute. As you look, notice, what do you smell? What do you hear? What do you taste? And how does it feel? what's your eye drawn to? What contrast do you notice? And you can write this down if you like. You don't have to notice all these things, but use these questions to spark your attention. Okay. Ready? Go for 60 seconds. Leave it there. Okay. So with a smaller group, we'd usually have more time to do this, and then we'd have a discussion about what we noticed in this text. But in lieu of that today, I'll share some responses of others who did this exercise before. One person said, I smell smoke and choking chemicals that make your eyes water. Another said, I feel the vibration of the road, motion. It's an in-between space, though. And someone else said, I taste a smoky, dry wind, grit in the air, depletion. It's been sucked dry. Someone else, I can't decide if I feel angst or if these women are headed out as heroes. And lastly, the contrasts I notice here are the vitality and the exhaustion in the women, the bright red exacting signs in a post-industrial landscape. So I wonder if you noticed some of these same things or very different things entirely. So now we're going to move right into a writing exercise using a prompt. And this is a timed writing in response to this prompt. So respond to the prompt in the shadow of the text that we just looked at, the painting. Just put your pen to paper and start. Whatever comes out, a memory, dream, poem, there's no right answers. Even if you don't know what you'll write, just go ahead and start, and I'll be the timer. All right, starting now. We'll take the time, it's so short. Again, in smaller groups, we would take more time to write, 3 to 5 minutes as a timed writing, and then we'd take time to share what we wrote. But in lieu of that, I'd invite you to send your writing to me via email if you'd like to, because I'd really love to read it. So if you were curious, this painting is called Oil Field Girls, and it was painted in 1940 by Jerry Bywaters, a Texas artist, and you can see it in the permanent collection at the Blanton at UT, and apologies if you've worked on this text with me before. So we're at the 20-minute mark here. Do I have 5 more minutes? Okay. To finish up, we're going to do a kind of like narrative medicine version of speed dating. Yeah, so I'm going to start by reading what I wrote one time when I did this exercise, this timed writing to this prompt, write the story of your name. Jennifer, one of the most common names for girls born in the United States in 1970. It was Jenny through my childhood, Blair, from Clan Blair, a family name passed down through generations in memory of the Glencoe massacre in Scotland in the early 1700s that wiped them out. Pollard, a Norman English word that can mean either shrub or pole head or dull head. And Ruiz is the newest part of my name. It's the name of my husband's father's family and the name of my sons, and now I share it with them. So now it's your turn. There's 2 parts to this. There's the timed writing, writing to this prompt, and then the sharing. So let's just take 1 minute now to write the story of your name, and write with the awareness that you'll be asked to share. Okay, so now if everybody can look around to their neighbors and find a partner. And you're going to tell your story to each other. So use what's on the page or, parts of it, but don't contextualize it, don't explain it or preface it or do any of that. Just, also remember, whatever is shared or spoken, it stays here in this room. So when you're listening, listen attentively and pick out or write down one of these sense details that you hear in your partner's story. Okay? So we're gonna do the telling first, and I'll tell y'all when to switch, and then we'll do the reflection. So gosh, like 30 seconds each to tell your story, 45 seconds, and then we'll do just a very 20-second reflection. Okay. Go ahead and start. You started already. So go ahead and switch. I know it's hard. These are so fun to tell, but try to give your partner time to tell their story too. Go ahead and switch if you haven't. And in just a second, just in the interest of time, because I know everyone wants to enjoy this afternoon, otherwise we could just extend this, but we'll shift into reflecting. So go ahead and answer a few of these sense questions. What came up for you as you were a listener? What did you see? What did you hear? What did you taste? You can even say, I saw, I felt, whatever. So let's just do that briefly. So swap again, and you're gonna again tell your partner. Reflect. Well, I'm glad to see all of you guys listening and telling and reflecting. But just to respect everybody's time, please continue your conversations. But that would be the end of the talk. That's all for today, and I hope maybe you experienced something unexpected. Thank you all for contributing and listening and trusting me and each other.